of the national conversation. It's in media. We're continuing to hear about epidemics, overdose epidemics, prescription epidemics, a lot of confusion out there, a lot of concerns out there, a lot of initiatives out there. And so I wanted to try to help set the stage here to understand when we're thinking about substance use disorders and we're starting to think about these as conditions and treatment for these, what are some of the really, really important aspects that are involved? And again, I am a board-certified addiction psychiatrist, so I'm speaking about this as somebody who has provided that type of treatment across multiple different types of care. And we'll talk a little bit more about types of care in a little bit here. Let me first say what this isn't. This isn't a treatment. I am not your psychiatrist. I am a psychiatrist, but I'm not anybody's psychiatrist here. So the content in this presentation is for informational purposes only. This is not a substitute for medical, clinical, legal, or professional advice. Just because I'm a doctor that said something, it doesn't mean that I'm going against what your doctor said as part of an individual treatment plan or what your loved one's doctor said. So just want to make sure that that's very clear here. Florida Blue and Lucid make every effort to present complete and accurate information, but we can't provide warranty or say that this is completely accurate with all of the changing landscape and the information and the way that medical information changes. So just wanted to make sure that that's there as part of the disclaimer. What we will be talking about is substance use and what happens when somebody's using a substance and it morphs into what would be a substance use disorder, or how it progresses into a substance use disorder, if that's more helpful, and what's involved in that diagnosis. We're going to be talking about stigma. We really can't talk about substance use disorder without talking about how stigma affects individuals with substances, how to improve conversations in order to decrease the stigma, and to really help open the door and make it more fluid and easy for individuals who are struggling with substance use disorder conditions to get treatment. And then we're going to be talking about recovery. So when we're thinking about treatment, how does that fit into an individual's recovery plan, understanding some of these options, as well as this very important concept, which is called harm reduction, which just very quickly, harm reduction is about decreasing the negatives or making the bad less bad, or making the good a little bit better while helping prevent the bad from getting worse. Those are some of the main concepts related to harm reduction, and they make a big difference when we're talking about individuals with substance use disorders and substance use conditions. So when we think about somebody who's using substances, oftentimes we think about substances and that person's behavior as bad or negative, and that can help color things. It may sometimes be helpful that, like all of us, when we wake up in the morning, we're thinking about our day and thinking about how we're going to do the best for the day, how we're going to really help ourselves for the day. And individuals that use substances also have this. Sometimes their substance use, though, does fit into some narratives or themes about why they're using, and they can be, for that particular individual, really compelling and really, I'm not going to use the word good because that has its own terms, but really valid. I think that's a more appropriate term, a valid reason that somebody's going to use substances. Sometimes it's to help them cope with negative emotions or to remove negative emotions. You can see things like grief or stress. Sometimes it's to increase positive emotions like relax, or some individuals want that euphoric effect or enhancing their performance, that enjoyment of feeling high. Sometimes it's related to the demands of life and the things that are going on, what our family demands of us. And some individuals, their family actually promotes or contributes to the use and pulls them more into that. Some others, there's a distraction from that, and then can also create these negative emotions. You can also see career pressures, and then mental health concerns like trauma or individuals who are interested in instant gratification, the loneliness, and also then our other groups, like our peer groups. So just to consider that somebody who's using, and even when the use gets out of hand, we'll see that in a second here, even when the use gets out of hand, where it transfers or turns into a substance use disorder, it may have come from an individual really trying their best, and that their use stemmed from that. Not everybody who uses a substance is going to have a substance use disorder. And not everybody who even has negative consequences of a substance are going to have a substance use disorder, because sometimes those negative consequences, those bad things that happen when they use, results in them changing or stopping their use. Substance use, when somebody develops a disorder, which is a diagnosis, we use a manual in psychiatry called the DSM. It stands for Diagnostic Statistical Manual. It's in the 5th edition, and in actually a revision of that. That's kind of the gold standard for treatment professionals who will diagnose a condition. And there's criteria that says, hey, this is the stuff that needs to be there in order for this condition to exist. One of the real big ones is a pattern of symptoms, so continued, using a substance that an individual continues to take despite its negative effects. They continue to use the things that cause the bad things, even though the bad things are there. That's how the DSM finds it. And a lot of times we talk about dysfunction when we talk about mental health conditions or substance use disorder conditions. Dysfunction being one of those bad things that can happen. We're not doing as much as we could. It's taking a negative toll on us, and we may be losing our ability to accomplish some of the things that are really important for us to accomplish. There's the American Society of Addiction Medicine. This is one of the biggest agencies about addiction treatment, about definitions of treatment, about philosophies, and trying to develop a culture that includes whole person treatment. American Society of Addiction Medicine aligns with a chronic medical disease model of addiction, which says that individuals who have a substance use disorder condition tend to look like individuals with other chronic conditions like diabetes or hypertension or some other mental health condition, where it's not about you get this treatment and it makes everything gone and you don't have to deal with this again. It's that the treatment is there in order to make things better, with the illness still being there. And sometimes then it's kind of in the corner, not really doing a whole lot, but if we're not doing the things we need to, it can rear its ugly head. So American Society of Addiction Medicine describes treatable, really hugely important, we're going to talk about that too, chronic medical disease involving complex interactions among brain circuits, genetics, the environment, individuals' life experiences. So it really talks about our physical makeup, our genetic makeup, our culture, society, and also the way we experience those as an individual, and that moves into it. It also says people with addiction use substance or engage in behaviors that become compulsive and often continue despite harmful consequences. So you can see that there are the comparisons between the DSM and the American Society of Addiction Medicine in that last sentence. They use the word compulsive, like repetitive, and many times when we think about compulsions, it has that feeling like we can't stop. I think it really holds true for individuals with substance use disorder conditions, that they may feel like they can't stop. Look, I didn't provide all of the DSM-5 definition. This is not the entire one, several pages long. Wanted to keep it kind of in that more simple state, and just to kind of give you a frame of reference on what we're starting to talk about when we talk about substance use disorders, and different from somebody who's using or engaging with a substance without some of these problems, or not to this degree of problems. Here's some facts about when we are describing an individual with a substance use disorder. It's not one size fits all here. The substance use disorder does vary in severity, and it can exist in a mild state. It can exist in a severe state. It can also exist in different states depending on how recently somebody did use. Such as if they haven't used in a while, it could be in withdrawal. If they are continuing to use, it can be active. Might actually be that they've used so recently that they're intoxicated. Some individuals can be in remission, or they can be prevented from engaging in use because of various different things, which in a controlled setting, that if they weren't in that type of environment, they were going to be using, but they're not now. Ways to describe this, and if you have loved ones or have people who are working on describing the conditions, you may hear these different terms, and they can describe the substance use disorder in that more nuanced way to help understand where somebody is, what they're dealing with, how the severity is. and what we may have to leverage in terms of treatment in order to help that individual. We do know that substance use disorder and people who are using substances can impact medical and mental health conditions. This impact creates morbidity or bad effects to that individual, but also mortality, and can result in quicker death or even death right away. Part of the narrative related to substance use disorder and the mortality component is how quickly some of the substances that are out there illicitly can result in death. Unintentional, unwilling, sometimes even unknown because of cross-contamination. But that some individuals who are looking for their substance use and who are actually actively involved in their substance use, looking for substances, may also take substances that result in their death. So really important here. And again goes to other chronic conditions such as hypertension, diabetes, chronic pain in that medical model, and similar to those are treatable. And expectations of treatment can also help refine and define what we're thinking about for that particular individual and their own recovery. I mentioned that stigma becomes a very important concept that we need to get our hands around, as well as also understanding how we can work with individuals for this. And so stigma is that internalized idea of the way that they're perceived, and it's negative. So my perception of the way that people are seeing me, talking about me, using language to define me or my behaviors in a way that's overall negative. The internalized stigma does diminish self-worth and self-esteem. So if I'm feeling the stigma, it may decrease how I feel good about myself or how I feel about myself. It can interact with other mental health conditions, and in the concept of psychological pain, or the way that we feel that mental pain, mental anguish, stigma may feel worse. The way that I'm perceived for using my substance may feel worse than the actual substance is causing me to feel in and of itself. People who do feel stigmatized by loved ones, by treatment providers, are less likely to disclose what they're using, how they're using, and seeking treatment because they're afraid of the judgment. And they actually increase substance use. So as my negative feelings start to come out, if you remember that slide with all of those different things, one of the ways I may cope with my negative feelings is to use substances so I don't feel them, or to give me something else to feel that is not this negative feeling, like a feeling of euphoria. So sometimes that negative emotion that's tied into stigma can drive people into continuing their use. In treatment, when individuals are treatment, even treatment providers see people with substance use disorder as less honest or trustworthy, that they are more likely to overuse resources, not specifically for their substance use disorder, but for their other needs, and that they're less invested in their own health, that they're seen as, because they're continuing to use the substance as part of a chronic disease, that they're not interested in taking care of themselves because of the continued harm that's coming from the substance. People who perceive stigma, again, they may not overcome some of the barriers in order to access the necessary care. They may actually, in an effort to look better, sound better, and especially in some very vulnerable populations, not describe their use because of the fear of judgment. They're more likely to have difficulty in feeling that attachment connection to their provider, and may avoid interrupt treatment when they're feeling very stigmatized, so leaving and then not coming back because of the negative emotions that arose. This can happen within family settings, social groups, but also in treatment. And so it becomes a really, really important part of the narrative of understanding what an individual's experience was that may have resulted in the lack of effective treatment, or the leaving of treatment, or the difficulty in returning to treatment. So how do we combat this? How do we work with this? Guiding style of communication becomes one of the real foundations for human-focused, whole-person-focused. An individual is the best decider of their own life type of conversation, helping empower individuals to make their own decisions. It becomes collaborative, where we're working together on a same goal. And the refinement of those goals, when I'm not seeing eye to eye with my patient, trying to refine the goals to me better understand what the patient's going after so I can do my best in order to help achieve that, and to do my best to help the patient understand what my reasoning is or what my expectations were in making those type of goals so that we can mutually meet. Because have to have that respect for their autonomy, goals, and values. In that the individual, again, it's their life. They're going to be making those decisions related to their life. In that collaboration, it also means what is their readiness to change. We're going to talk about a framework for readiness to change in a couple of slides here. But how ready are they? Because there may be times that I'm more interested or invested, or I'm more ready for the person to make steps in their own recovery than they are. And again, working through the stigma and the way that even announcing and starting to work through that identification of a substance use disorder may be one of those difficulties or barriers to readiness to change. But there are others, and we're going to talk about some reasons that people don't go into treatment or that they may leave treatment. Ambivalence is always part of change. Because we can tend to come up with a pros and cons list for anything, any type of decision, it also means that I may kind of be sitting on the fence and saying, yeah, I kind of want this, but I also don't want this. I want something to change, but I really like this the way it is. I'm not quite sure, but this would be really better if I wasn't in this situation. And in that kind of, some people use the word hem and haw. Some people say, sitting on the fence. But it is that ambivalence. It's the I want the change and I simultaneously don't want the change. I want things to be the way they are right now, and I don't want things to be the way they are right now. Simultaneously, in the exact same moment, is the definition of ambivalence, and something really important to work through anytime somebody's changing, and it kind of goes in bold and big letters when we talk about substance use disorder. The guiding style of communication also identifies that the person's the best expert. They know what's going on in their life better. They might not know what my interpersonal impact or what my feelings are about what's going on in their life, but they certainly know what they feel about the way that I'm interacting better than I would. So they're the expert. They're also the expert in what, how they rate their values, how they rate their the pros and cons list, how they're making determinations here. And because of that, it requires a sense of empathy and respect. So we are using that word respect here again. Empathy, that emotional attachment, and saying we do care for them. We may not like what's going on. We may not like what they're doing, but that doesn't change that we will have emotional attachment and even love related to these individuals, and especially for our loved ones. And we try to do this in a non-judgmental way. The better that we're able to reserve our own judgment in order to understand what's going on, the better we may be able to truly work through the barriers, the problems, the hurdles in order for an individual to make that meaningful change as part of their recovery. And sometimes that does mean that they would enter into treatment. When we think about treatment, I did use the word whole person before. Patient-centered care is another way. It's a very busy slide, and I appreciate that. And one of the reasons why I wanted to share this slide is to highlight some of the themes that we've already mentioned in these pie slices, where care is collaborative, coordinated, where patient and family viewpoints respected and valued, patient and family always included in decisions, family welcome in care setting, full transparent and fast delivery of information, that these tenets, these concepts that are involved in that collaborative approach, that integrated approach, that hearing the person's voice, and when they have somebody that they love that they want to include, ensuring that those individuals are included and respected in order to better understand where the focus of treatment is, where the supports are, where some of the gaps are, in order to best to work on that. The goal is to improve the individual outcomes. We're there when I have my patient. It's my patient, right? Like, okay, I may have 20 patients a day or however many patients a day, and sure, I'd like my good day to help as many of them as possible. But when I'm in there with that one patient, that's really my focus. And so it really is about individual outcomes. And in that sense, with loved ones and people that we care about, it is about them too, and about what their individual goals and outcomes would be and how we fit into them. By doing this, we also see that outcomes actually can improve, and that working through this integrated patient-centered approach can get better outcomes, because we're focusing more on where the problems are, where the hurdles are, rather than just saying this is a diagnosis and as a label and a definition. And if we just treat this diagnosis in a vacuum, in this abstract concept of saying you have this type of substance use disorder, it may not manifest in the same way, because we're not working through some of those granular and really, really important aspects that are that can impact an individual's recovery. It is the word trust in here, right? Trust, personal interactions with two-way communication, where there's a give and take in that, and in the communication being able to both listen and also speak, to hear and also to be heard, and being able to work through those as part of this entire wheel concept here in order to really get to those outcomes. And you all are tremendously important in the people's lives that you love, that you care about, that may be struggling with substance use disorder, that you've seen. And if you haven't seen them, it's likely that at some point in your life you will, because substance use disorder is so prevalent out there, or individuals who are starting to slide into substance use disorders are very, very prevalent. So I did promise you that I was going to talk about the readiness for change, and how that could be conceptualized in a model. And this is the stage of change model. And it does work through those concepts of ambivalence. So if we think about this model, it's that the change in behaviors are eventual change occurs continuously through a process. Now, I use the word cyclical here because the arrows do go around. The difficulty is that it's also on layers. So an individual may be in an action stage of change for one element of their life and still in pre-contemplation for other areas of their life, maybe contemplation for, and when we think about for substance use disorder, they may also be in that same a layered framework. So let's go through and just define some of these. Pre-contemplation means I'm not even thinking about it yet. It's not even on like my radar. It's just not there. Contemplation is when all of a sudden I'm starting to see something that says, maybe I should change. And it's that maybe. And this is where the ambivalence comes in, which starts to say, I'm thinking about it. I'm thinking about what it would take. I'm thinking about what it would mean. I'm thinking about how I may be bringing people along or leaving them behind in this. And so I'm weighing this out. That's the contemplation. Preparation stage of change is where I'm starting to get things ready. I'm starting to do, prepare a plan. Maybe it's that pros and cons list where I'm starting to focus on the pros. I'm starting to evaluate and plan for what I'm going to do in my behaviors, that these are still kind of thoughts and a strategy in my mind, and I'm not ready to actually take the step yet, but I know what steps I have to take. That's the preparation stage of change, right? Starting to get some names for doctors, getting some better understanding of the medications that are out there, getting an understanding of my social system that would be interested in supporting me, maybe starting to work on some dialogue that I would have with my loved one in order to help with me making that next step, and that next step being action. Now I'm actually going through and I'm attending the appointment, or I'm having the conversation. I'm picking up the phone, or I'm going to a trusted provider in order to have this conversation. Through the action stage of change, and there can be multiple actions, right? And again, can go back to pre-contemplation. Wasn't even aware medications were available. Then I have to think about it before then I prepare and figure out whether I can, do I have the money and these kind of things before I get the medication. So they can have these different layers. Overall, we move from action to maintenance, which in the maintenance phase, we're continuing. We're at a new level and we're holding on to that level. We can continue to engage in this layer, going through pre-contemplation, contemplation, preparation, action, maintenance. Sometimes pre-contemplation is not necessary. It could just be contemplation, where we get to a further higher maintenance. And it could be that we're well enough that we can terminate from treatment, or we can terminate from the engagement with the person that was addressing the stage of change. Unfortunately, sometimes individuals do return. They do regress or return back to problematic behaviors. They can return back to their substance use, and then may have to go back through elements of this. they may be very aware, and again, don't have to go through pre-contemplation in order to go to contemplation, but many individuals do. So it kind of gives that framework. And so when you're if you've ever talked to somebody and been struggling and worried about how come they're not making the change here, this just seems so evident, it might be helpful to first guide style of communication, learn and respect that they may be making this decision for a good reason and understand that, but also to help gauge and say, I wonder where they are in this. Maybe they're not aware yet. Maybe it's self-evident for me, but maybe they are actually not aware. Or they're struggling with some of these aspects, right? What are some of the barriers or the hurdles again that could prevent them from pursuing the treatment? Because people may not accept treatment for really good reasons. They may be very concerned about their privacy and the way that if they're going to meetings in their community, how they're going to be viewed, right? And this layers right into stigma, which is most people who are thinking about their community and saying, wow, I'm going to go into this meeting and people are going to see me as using substances, aren't thinking everybody's going to be proud of them and give them the attaboy and say, oh, congratulations that you're here, right? There's going to be the sense of like, oh boy, what are you doing here? What's the concern there? Because that stigma may still linger. The better we can address that, again, the better we can help this. But other things, we use you may have heard social determinants of health, or social determinants of health as a concern for individuals not getting into treatment. Social determinants of health are those things that are involved that can negatively impact things like transportation, cost effectiveness, ability for childcare, our duties, unstable housing. There are times that the treatment that we're looking for may not be available. And this is where individualized treatment comes in. There are certain treatment types that are available for some substances, but not available for others. Medications are one of those. Look, the cost, the concern, and in a way, the fear of failure, that if I'm starting something and I don't get to that 100%, what somebody would say is abstinence or clean or sober, then I'm going to see myself as a failure, and it may result in an additional emotional toll on me, bigger than if I didn't try in the first place. Or if I never had to confront the fact that I'm a failure. I think we can redefine that. I'm certainly not in the position to say that the only way we would define an individual in recovery is to say that they're 100% not using or they're completely absent or sober, and that's where the harm reduction model is going to come in, and that's another one of those plugs that we're going to get into, because substance use disorder does have many paths. Not everyone with substance use disorder needs the same treatment. The treatment that is available for one type of substance may not be available for the other type of substance. Something that's really good and helpful for let's say, alcohol, it may not be as effective as, let's say, somebody who's primarily involved in cocaine use. So the type of substances can matter. Where the person is, what's going on in their lives may also help determine what type of treatment, what elements of treatment are necessary to be there. We don't need somebody to hit rock bottom. We don't need somebody to say, I'm in agreement that I'm never going to use any substance for the rest of my life. This is the time that I'm signing up for that, in order for us to say you can start treatment, because we can make meaningful interventions when somebody's already starting to have problems. And it may actually be that intervening at those times can help prevent the problem from getting ever bigger. That a person may not have to have such catastrophes in their life of reaching rock bottom before they start working to improve their lives. And again, I know it's a little, I'm saying this a lot, working through the stigma, working through the ability to communicate what's going on in order to make a real difference may help improve the person's ability to start when things aren't as bad, before they say, I'm already negatively judging myself in a way, and I'm now finally, it's not going to hurt as much if I'm getting confronted with everybody else negatively judging me this way, or feeling it that way. It really may make a big difference in getting people started in their recovery earlier with less damage. I do want to bring this out, that even when we think about somebody in treatment, it doesn't mean a particular level of care. A person may require hospital-based inpatient level of care in a hospital. They may require 24-hour level of care, which sometimes called inpatient as well, also known as residential treatment centers. People do not need to go away from their homes. They don't have to go away from their loved ones in order to be in treatment and to receive meaningful treatment. Sometimes there are challenges when people are leaving away from their home, which can prevent us from being able to really understand what's going on there and what was driving or contributing to the substance use. People can get involved in intensive outpatient treatment, partial hospital treatment, where they're going several days a week. They're seeing, they're in groups, they're involved in interactions with providers, can include medications. And then there's the outpatient treatment, which is what most people typically think of, or when you're seeing your doctor, maybe once a month or every several months, going to the clinic, having a scheduled appointment and following up. Outpatient treatment can be there. And the cadence for that can also be different. It can be on a matter of weeks, months, but typically in outpatient treatment doesn't involve years. These levels of treatment are integrated with other supportive aspects of treatment. Many of them can include things like AA and NA built into the structure, but they can also work alongside those type of supportive aspects, which brings me to effective substance use disorder treatment typically involves counseling and that one-on-one conversation, working on those individual aspects, improving the ability to cope when not using, and to be able to cope through the recovery process and some of the difficulties that may occur. It can include medications that can address an early condition like withdrawal, can also be as part of a maintenance package. And there's the slide at the next one that may talk about some of the So some thoughts about the medication. And then there's that recovery support, things like Alcoholics Anonymous, which is community-oriented, Narcotics Anonymous, which is community-oriented, Smart Recovery, Celebrate Recovery, mutual help groups. These are not separate from what may be involved in church or community settings or certain families or cultures that would also help support an individual's recovery. So this is not exhaustive, but just gives that framework that the talking part, working on the medications, and also having that wraparound support, these are elements that speak to effective substance use disorder treatment. If we remove any one of these elements, it doesn't mean that a person's not in treatment. It can change the effectiveness of it. Medication for substance use disorder treatment can be used as a primary focus, and sometimes this is what helps individuals get started in their recovery before they're able to take some of the more advanced or more integrated aspects down the line. And let me be very upfront with you, there are people who won't. That medications are really the primary part, and that's their recovery. That's where they're at. That's what they're going to do, and that's what we see as that benefit, which is really, really great for those individuals. So got to work sometimes at understanding where we push for more and when the current is enough for right now, or maybe even enough. Medications are not a substitute for one drug for another. This is not like Dr. Ligas prescribing somebody with an opioid use disorder medication to address their opioid use disorder, and I'm facilitating them getting high, because the thing we see about the medications is that they result in improved outcomes. They make people better. They help people function better. They take away some of the negative challenges that an individual may experience while in their recovery, such as relieving withdrawal symptoms, improving physiologic craving. Again, they're effective if used alone or with behavioral therapy. These can help start individuals in substance use disorder. Some people who've already started and seeing some challenges, they may be used to add on to and include in their substance use disorder treatment. And the cool part about this part is there are medications that are still being explored right now in research, but they're not out yet. So we don't even know about them yet. And so somebody in recovery may have another opportunity when, as these medications, the research starts to come out, of figuring out how those medications then start to incorporate in their own individualized treatment plan. This is important in informed decision-making in recovery. If somebody doesn't understand how medication can help, what the risks of the medication are, the benefits of the medication are, they may not be making the full informed decision about their recovery. They may be having only one eye open in what's an opportunity or availability in their own recovery. We do know that for individuals who receive medications to have those prescribed. The support from family and community increases effectiveness. And again, when the family or community are not supporting that, it can erode the effectiveness of the overall recovery and may actually result in eroding of the medications taken the way they're supposed to, or maybe even the effectiveness of the medications at all. So I said the word treatment enough, maybe enough right now, or maybe enough and it's just enough. And this does speak in some ways to what we're talking about, harm reduction. The overall model of harm reduction is meet the person where they are, recognizing what's good, what's not good, recognizing what they're interested in, what they're not interested in. A harm reduction has the belief that any step in the right direction, and the right direction is by minimizing negative effects, not trying to glaze them over or try to prevent working at trying to prevent the bad things from happening, and by doing so can help work for an individual into a better understanding of how they can continue to address their substance use. It could also be of decreasing or lowering the overall problems related to substances and keeping those at bay so that they never rear their ugly heads in that fashion. And really, when we think about harm reduction, it's about the outcome. How are we altering an individual's course of their recovery by decreasing the bad things, increasing the good things, or preventing the bad thing that's happening from turning into something that's even worse? So what this does is it broadens the spectrum of people that we can engage with. It doesn't require, this is 100% in that stance of a person doesn't have to say, I'm going to be abstinent from everything from now until forever in order to work with them. We can say, what are you willing to do? What's the worst thing here? If the alcohol use is the worst, and that's what we can tackle right now, that may be something really, really important. And the person saying, I'm not planning to stop my cannabis use, or I'm not planning to do that. And we can continue and say, okay, what's the plan? If the alcohol is the biggest problem, let's work developing a plan to address that. We're going to hold our opinions out about the cannabis. We're going to continue to talk about that and evaluate that as things go on. But we don't have to tailor that right now. Just recognize and help inform an individual making them. So the abstinence is neither prioritized or soon to be the goal of the person, and even depending on their substance, right? Harm reduction, why it matters. The traditional practice was that ultimate goal is abstinence, person coming in saying have to sign that contract that says now and forever, which also increases the concerns about stigma. The perception of use and problems are in a one-to-one agreement, saying that if you're using something at all, that's the problem. Can't use anything, and then we're going to remove the problems. It puts physicians like me in a position where I'm prescribing treatment. I'm dictating what's going on. I become the expert. I know best. I'm telling somebody what to do, and if they do it, then they're successful, and if they don't do it, they're a failure or a problem. And that it's abstinence is the only or the best way forward, which is, again, in order for me to take my first step, I have to say that I'm willing to take the 100,000th step in order to take the first step. Different in the harm reduction approach. Goals reducing harm. Again, lowering that bad stuff, maybe improving the good stuff. Recognizing the risk of problems is variable and it's individually based. What somebody's perceiving as the particular problem or the issue may differ. Provider, I offer the information through science, through knowledge. Family members, loved ones can provide it from their own perspective in order for the individual to assess and reassess and re-understand and redefine their harm. Patient knows better about their lives, again, putting them in that position of autonomy, putting them in that position of they're the decider, they're the decision maker in their own lives, and keeping the patient alive and on a path towards reducing harm is the best way forward. That we're much rather a person will be willing to take a few steps and then figure out where things are, rather than saying I'm promising to do the 100,000th step in order to take the first step where people may never even get there. We have resources that can help support individuals in their recovery, and some of these resources are where I pulled some of this information. Places like SAMHSA, the Mental Health and Substance Use Agency, Center for Disease Control and Prevention, the National Council for Alcohol and Drug Dependency, Alcoholics Anonymous. Even though it has the word alcohol in the name, there are many Alcohol Anonymous groups that are willing and accepting of individuals with other substances. There is a difference in philosophical stance between Alcoholics Anonymous and Narcotics Anonymous in some places. And so some people feel, regardless of their substance, they fit better with Alcoholics Anonymous. Some individuals with alcohol or other substances feel better, they fit Narcotics Anonymous. And these aren't the only ones. There are those other ones, Smart Recovery, Celebrate Recovery, that are also involved. And for family and loved ones, Al-Anon and Alateen, having support for the hard work of living and loving somebody who has substance use, problems related to their substance use, and maybe even substance use disorder. So it can be really, really important of helping the people that are asked to help. There are ways for individuals to alter their tobacco, and Tobacco Free Florida is assistance in quitting, because even though I haven't mentioned it, and we aren't, working through tobacco use fits, and it is in the substance use disorder section of the Diagnostic Statistic Manual. And in fact, tobacco, changing somebody's tobacco use may actually have some real fundamental improvements in their ability to stop or change other substances as well. And there's also the AHEC related to tobacco and help for tobacco use as well. That's what I had for my formal talk, but obviously I'm here for questions, and happy to answer any I can. Thank you so much for your attention. Thanks for your interest in coming in and hearing a little bit about some of the concepts here on substance use disorder. Can't thank you enough for that. And if I don't get your question, I just want to say, wish you all the best out there, and for all the things that you guys do in your family and your society. So thank you.
Yes, thank you so much for presenting on this topic today. So we got one question that came through, and I want to ask that. So yes, it's treatable, but how do you convince the person to get help they desperately need? When someone's so sick with mental illness, how do you show them they're sick and using substances is not helping them?
Yeah, that's a great question. I'm gonna say delicately, and also with difficulty, because let me just start out that if you're asking that question, I'm assuming that there's already been an attempt in order to have the conversation or to show them, and it hasn't worked, which means that this isn't the one that just says, when I show them and they see, they're going to know, which might mean that there's something else that's going on here. And certainly there are interplays between mental health and substance use disorder where each one plays off the other and it makes it worse. It may be very, very hard for somebody to see how much mental health struggle they actually have, because they're not going to experience all that because of the substances, and they may not understand as much of the substance because their mental health is changing how they're experiencing or understanding their substance. So it may, how you do that it may also require some assistance. If the individual already has their provider, and I'm going to go back to this slide. I know it's quite a busy slide, and it may also help guide to some of the struggles that you're having in helping your loved one understand what's going on here. It may be helpful to leverage the people that they're already interacting with and becoming a partner or a contributor to the overall treatment goals. It may also be that because the person themselves aren't aware or aren't able to see the difficulties, it may be that the provider's not having that translation, and it actually isn't part of the treatment plan because there's no awareness of it. It's not on the radar. And so if there's an opportunity for you to engage in a loving way from a stance of support, information gathering and information providing in a caring way, not to overstep the person's own rights and respecting their own efforts in their life, to partner with the provider, it may help shed some light to the provider. It may also help shed some light to the person that's struggling with that it isn't you trying to take control of their lives or dictate to them, but really in a loving way trying to say that you're really concerned that there may be problems here and that these problems might be worse. And it also might mean that the person may say, look, I'm not willing to do this, but I'm willing to do that. I'm not willing to completely give this up, but I am willing to not use one around you. Or I am willing to let you know that I had just used in order for you to make a decision about what you're going to do with your day or the responsibilities there. So that kind of dialogue and that two-way conversation may be helpful. Look, again, this is where it gets a little bit difficult. Generally advisable not to have conversation with somebody while they're intoxicated. Also, if somebody's in the throes of a mental health emergency, that's not the time, right? We've got to take care of safety first, got to be able to take care of those things. And in emergency situations, there may be opportunities to take for temporary direct interventions that require emergency department and even involuntary placements. There's statutes related to that, and many of them are available. Excuse me, through community mental health agencies and through the particular state that you reside in to understand what those avenues would be. Got to be careful. I want to say this carefully. Many of you say, all right, well, if you force somebody into treatment, then they're in treatment, and once they're in treatment, they're going to love it. And that's not always the case. Sometimes it can be very, very uncomfortable with somebody. Say somebody took ownership of their own responsibility in a way that directed them, and it can result in some erosion. So it does require some of that risk-benefit ratio kind of thought process.
Great, thank you. So somebody asked, should our approach change in working with children and adolescents with substance use disorders?
Wow, great question. So should the approach change? None of these themes here were saying this is only applicable to an adult. And when we're thinking of, so in general, when we're thinking about substance use disorder, and even the way that the American Society of Addiction Medicine defines it, it's not children, it's adolescents. And if there are children that are engaging in substance use, it may be a separate problem, which may speak to different agencies that may have to step into where a child is accessing or engaging in that severity of substance at that particular age. Adolescence, when we're starting to, as part of our normal human development, exhibit our own independence, starting to separate from the ownership of people telling us what to do, but maybe not yet in the position to be able to tell ourselves what we're supposed to do. The peer structure are all of the changes that are occurring during adolescence that involve our social engagement, our thought process for what's happening as we're transitioning to adults and all those things. That's typically where we see addiction-focused treatment. That's where we start to see evidence and research related to substance use disorder treatment for children, and that's where we see the transition to substance use disorder for an adolescent. There are specific treatments that are focused on adolescents. None of the concepts that I said here are directly related to adults only, even medication. They have to be carefully weighed in on what's going on. And certainly the big difference, though, is that the autonomy of the autonomy of an adolescent is directly related to the fact that they're a minor, which means that they aren't able to express the full autonomy as an adult that may have the legal requirements that they can do things that an adolescent can't, because there's the parent or the guardian or the agency that's also involved that needs to make meaningful decisions and informed decisions. This concept that a adolescent agreeing to a treatment plan that is focused on their own goals actually may be doubled down in adolescence. And so a parent making a decision unilaterally without considering what the adolescent is looking for tend to have less good outcomes. The alignment of parent, guardian, adolescent, and treatment goals in that kind of can really move the needle for the adolescent in treatment, and also move the needle in expectations of the parent.
Yes, absolutely. So our next question, would MAT be similar to replacing one drug with another? And is it possible to explain a bit further of the MAT benefits?
Sure. I use the word medication because I didn't want to fall into this MAT thing, but that word's out there. And let me just say this. It used to be called medication-assisted treatment, which was actually facilitating some stigma, because I don't think anybody would ever say that medications were assisting some other thing in other chronic conditions. It's not like this medication is assisting my hypertension through my diet and exercise efforts, but I'm taking the medication. It's just a medication. It's a medication for a condition. So we've changed that language actually over the last several years, and it is starting to trickle out. So when I use the word, if I would use the word MAT, I would say medication for addiction treatment. You may also see things like MAUD, which is medication for alcohol use disorder, that medication specifically for alcohol, MOUD, which is medication for opioid use disorder, and specifically focusing on opioid use disorder. And it's not, even though the medications may work on pathways that the substance also works on, the objectives for the medication are different than the objectives for the substance, because the medications are there to facilitate and promote recovery. And they're there as part of an ongoing conversation related to the prescription of that as part of a comprehensive treatment plan. It is part of treatment. It is something that has been shown, and the evidence continues to show that it makes people better, not worse. Even if it's supporting a pathway that got out of whack because of somebody's use of substances, it creates stability, and it creates some routine related to those pathways that can facilitate somebody to improve their functioning. And those are the overall goals, which isn't I'm using this to get high, or I'm using this to avoid negative emotions, or I'm using this to not accomplish the things that I'm in life or tolerate these people from negatively judging me. This is actually me taking a prescribed, approved medication as part of my individualized treatment plan that is helping me live my life better as we defined it in that treatment plan. And the evaluation of whether that's something that should continue or not is also through the evaluation on those outcomes, which means that it is something that a participant or partner of the person writing the prescription has the opportunity to say, this is no longer helping. The risks of this have changed. The benefits of this have no longer shown themselves. We're not in a position that this is safe or effective for you to continue, and therefore we're not going to prescribe it anymore, which is very different than the way that individuals use substances, because when that happens, they may actually re-engage in more of trying the thing. So quite different. Lastly is that these medications, there are medications that activate, there are medications that block, there are medications that stabilize certain receptor pathways, and the way they work isn't by saying you're just got this new thing that you're going to become dependent on versus this other thing that you had dependence on. For sure, there are times where individuals take enough medications for long enough. There has to be a careful and considerate way to take them off, because negative consequences like withdrawal can happen, but that also happens to other medications too. It may not be safe for you to stop the high dose medication that you were on. It may require you to lower and lower the dose in order for that to not have such a negative effect. So it is in that medical prescription model that focuses on positive outcomes, focuses on improvements in functioning, and working on those things to make things better.
Absolutely. Okay, so we have time with one more question here.
So I do want to just quickly say, Gabrielle,
Sure.
Kelly, it's not that MAT is phased out. It's that MAT's so prevalent, and it's like in so many places, it's the way that those letters are defined now that's different. It's no longer medication-assisted treatment. It is now moving towards medication for addiction treatment, or that's pretty medication for addiction treatment is pretty much the one. There is one more, and I'm just blanking on it. So it's not that those letters got phased out. It's the way the letters are defined. No longer saying that this is something that goes along. It can be and is effective when used as a treatment in and of itself, no different than other medications that are out there.
Absolutely. So one last question. So based on the last questions that we just answered, for an adult teen, hard to find care due to multiple issues, not sure what the diagnosis is primary and seems to feed off the other, stuck in a cycle of treatment while the issues get more complex, adding complexity of age, not sure where to start.
Yeah, I hear you, because there are these gaps, and there are times where an individual having multiple conditions may prevent the acceptance for specific, and I'm going to use the word siloed. I think people understand what I mean there when it's saying this is addiction treatment, and then this is mental health treatment, and this is physical health treatment, and this is medical treatment, and this is social treatment, and this is your couples counseling. What we see is when things work best is when they all kind of wrap around each other, and that's where we use the word whole person care, the patient-centered care, the collaborative approaches, and so in general, best opportunities to is to gain the best understanding related to the condition that you can from the people that have already provided some treatment, or maybe even are continuing to provide the treatment, to get that best understanding, to hear the recommendations of the treatment providers of what they were recommending, and if there are any specific, and I'm going to use this word, any specific modalities that are best suited for that person's condition, and then to try to crosswalk that with if you have an insurance provider like Florida Blue, or other insurance provider, to understand who's managing that part of the benefit for that particular modality as the priority, and then advancing the narrative there and understanding. There are times that individuals do require to leave the place where they're living, where they're working, where they're playing, where they're housed or going to school, in order to receive the most appropriate treatment. It's a very, very careful, I'm saying that it's a careful decision. There are some people that believe that that's how you have to start. I absolutely say that that's not. But there are times where that is where somebody has to start, because the resources that are necessary are just not available where they are, and they need to seek those resources elsewhere. And so it is a complicated process, and individuals who are working through these multiple different areas often have that similar struggle of saying, I found somebody and then it wasn't the right fit, or I found this person and they weren't the right fit. So getting that better understanding from the people in order to then say, this is what a fit would take, may help guide and land with a better match.
Yes, absolutely. Okay, well, that's all we have time for today. Please take a moment to take our evaluation. You can use the QR code that you see there. Just point your camera to that QR code, and the link will pop up to take you to the survey, and we do value your feedback. We've got a couple handouts for you. We'll provide the handouts in the follow-up email, along with the recording too as well. So thank you so much for participating this afternoon, and thank you again, Dr. Ligas. We really appreciate it, and I wish you all a great rest of your day. Thanks so much.
Bye, everybody.